I got here and I thought I was late and the three commissioners weren't here.
Yeah, and one of them was me.
You being one of them.
And then when I got in here, I'm like TikTok on everybody else.
That's right. I say, what
Wait
do
a
you
minute.
think you're doing?
What do you think I am?
Hey, I was the first one in the room.
Yeah, I know. It's my fault.
Yeah.
It's okay.
All right.
Y'all can report that it was my fault that this meeting started.
We'll call this workshop to order at 7 minutes after 10, Tuesday, April 18th, 2023.
All right, Judge.
Okay, Greg.
A few reports ago, maybe back in November, when we started seeing some revenue on the air billing side, there was a lot of questions over IDR processes and how the timeline from, I'll call it bill maturation, from sending a bill to a patient to when we get full collection. Why does that take longer for air versus ground? I told you we'd put together a workshop on that specifically. This is not a Metro update just for the medias. This is not like operationally or tactically how we're doing with Metro. That was all reported about 3 weeks ago during my annual report. Even the financials, this is more about the billing process in general. I brought two of probably, to me, you guys trust me to surround myself with good people, and nobody knows everything. I certainly don't. But they are, to me, the national experts, and I'm going to talk them up to see how well they do in this forum here in a minute. But Kim Stanley is the Chief Operating Officer for our billing company. I met Kim back in 2011. We put out an RFQ for billing services. And in fact, Commissioner Hanneth, I think that might have been one of the first trips that me and you went. We went and actually visited North Carolina. I was hooked from the get-go because they knew what relationships were. And Kim's kind of an anomaly. She survived several transitions of new bosses and different things. And to have a friendly face for that long in that industry is uncommon, I would say. So she is a text and a phone call away, always, which is really cool, and that's uncommon too. Normally there's 4 or 5 people in between me and her that you go through to get to somebody, but literally we can pick up the phone and text and call. And then Metro has a vested interest in, and you correct me where I'm wrong on this, but Holly Weber is a Metro employee and Director of Revenue Cycle Recovery Support Team. I'd probably butcher the terminology. I'll let her introduce herself. But Metro has a vested interest in seeing us succeed. And they surround themselves with subject matter experts that do really good work for a living, because if we succeed, they succeed, is the way they see that. So part of what we pay Metro for, we get this asset. And she is a wealth of information on the helicopter EMS world, not just revenue recovery, but she's done a little bit of everything. So I'll let them introduce themselves, and really this is their show. They're going to tag team this. But if you have any questions, it's very informal. I'm not speaking for them, but they're not going to be upset if you interrupt and ask questions either. So who's got the baton first?
Did you warn them of us before?
I warned them of some of y'all.
Oh, okay.
So,
That was.
Hey, are you pointing at Dustin? That looks like Dustin.
Well, good morning, and thank you for having us, commissioners and judge. Happy to be here. My name is Holly Weber with Metro Aviation. Just to be straight, we are your aviation vendor for Washington County Air One. We don't do any billing. We don't do any of your clinical stuff. We actually do stick to the aviation lane. My role is a customer support role in the world of revenue cycle management and compliance. And I work directly with your billing team, which is represented here by Kim Stanley and EMS MC, as well as I work with our 42 other partner programs across the country to help make sure that everything that's going on the aviation side is integrating with the billing side and kind of keeping things moving forward, really. My background is in revenue cycle management for the air and ground industry, and I've been with Metro Aviation for a little over 6 years now. So I was asked,
No Surprises Act? Is that an actual act?
Yes, so this is part of why we're here, to talk about the No Surprises Act. We're going to focus on the air ambulance portion of it. The No Surprises Act came under the Trump administration as part of the end of the year Consolidated Omnibus Act, and it impacts all of healthcare, hospitals, physician groups, all of healthcare. Massive piece of legislation to really get under control the surprise billing, the out-of-network billing, and the big balance bills that you saw historically in many different sectors of the medical market. Air ambulance, we got called out on that one for the first time in history because of our history of bad behavior, which we're going to talk about. Let's see. Whoops. So our agenda this morning is to give you an overview of the No Surprises Act, kind of how we got here as an industry, talk a little bit about the NSA and the litigation. NSA is the No Surprises Act abbreviated. We're going to talk a little bit about the air ambulance requirements under that law, as well as what's going on in the independent dispute resolution process, which is a significant part of making it all work. And then we'll talk a little bit about the ground ambulance piece. Kevin said, so let's start with how do we get here with the No Surprises Act. Historically speaking, air ambulance programs were hospital-based. In the early 90s, as you started seeing more and more helicopter services out there, most of them were tied to a hospital. And then somewhere around 1997-ish, there was a review of the CMS fee schedule for transport, and that's when the costs were looked at for air ambulance services, and a fee schedule was put in place that came about driving more and more people to get into the market, to get into the industry, and different models started appearing, not just hospital-based. We had some community-based models popping up. We had some alternative delivery models. And over the past 20-ish years, we've seen those models kind of grow and explode in different types of backings. And these are some of the typical headlines that you have seen probably the last 5-10 years about air ambulances in terms of sky-high balance billing, because the charge rates in the industry have continued to go up based on the variety of different models out in the market.
Can I ask you real quick, based on the current, I don't know, industry, I was gonna say market, industry, have you seen any other models like what we're doing here in Washington County?
Yes. It is a very, in terms of it being a municipally based model where you're providing your own helicopter, you're doing the clinical staffing, and you have a billing partner. Absolutely, it is a very common model. That's the only model that Metro Aviation works with. We're what's called a traditional aviation vendor. So we only partner with programs that will do. They handle everything else, all the clinical, all the billing, all of that, and we just do the aviation service. So that is our model type of choice, and those are all of our partners across the country.
How many of those are county governments as opposed to hospitals and
municipalities?
So in terms of a municipality, I believe you're our only municipality. We have some that are standalone EMS services that have contracts in various counties, but not a county municipality. So this is a unique, yes.
I'm glad, thank you for clarifying, that was what I had intended to ask. I just don't think I asked it appropriately.
So yes, you are, as far as I know, our only municipality from the true sense. Absolutely. So this is what got us the big attention down in Washington, D.C. Headline news, lots of patients complaining. What would happen when we get these high bills is, the air ambulance vendors oftentimes would pressure the patient. You've got to help us get your insurance to pay for it. Otherwise, we're going to put a lien on your house. We're going to make you pay on this forever. And they were high profile stories. You would see them, weekly in the news, weekly in the paper, all over the internet. And Washington, D.C. took notice. And when the No Surprises Act and all of the different, lobbying groups hit on Washington, there was a big component saying, well, we need to include air ambulance in this piece of legislation because they're a big offender. And it didn't matter who you were. Everyone was painted with the same brush and said, we need to fix the problem. So then came the No Surprises Act. It was actually signed into law under the Consolidated Appropriations Act of 2021 by President Trump, December 27th, one of his last signatures in his office. The goal in general of the legislation was to end surprise medical bills, including balance bill to patients. And again, air ambulance is kind of like the fly on the back of the elephant. They were really targeting all of healthcare, physician groups, a lot of the big for-profit hospital systems that have gotten really abusive with their billing practices. But air ambulance was high profile in the news. Our bills were huge in general as an industry, and so we were included. The other goal of this part of the law was to provide cost savings to patients and to improve the healthcare delivery system in the longer picture, bigger term. So the law was written to be implemented by 3 federal agencies: Health and Human Services, Labor, and Treasury. So to not only have this kind of legislation, but have 3 federal departments being in charge of overseeing and rolling it out, this was a big deal. And for air ambulance, this was the first time that we actually were included in legislation, because formerly, anytime anything came up about billing or reimbursement, air ambulance falls under the FAA's Airline Deregulation Act. And so we were never allowed to challenge routes, or services in terms of, or rates, routes, or services in terms of air ambulance, because we were protected under the ADA. Well, this now, as a federal piece of legislation, changed that. So this is the first time it's like, hey, yes, we are going to talk about your rates. We are going to talk about what's going on relative to the air. So I'm not going to go through every single one of these bullet points, but what ended up happening as the law got rolled out administratively, CMS was charged with writing the rules to implement the various sections of the law. And the law focuses on commercial out-of-network payers exclusively. It's not your Medicaid, it's not your Medicare, it's really focused on the commercial out-of-network payers. And so the CMS was charged with writing rules to implement that. And in the law, the kind of the basis of it is that there's got to be some kind of base level payment to start with when they're talking about what does it cost, what should you be reimbursed for these services. And they call that the QPA, or the qualifying payment amount. And the QPA by statute is supposed to be based on each insurance plan's median contracted rate. So if an insurance plan had 3 or more contracts for that particular service code, then they could come up with a median amount, and that would be the QPA, which would be the starting point in terms of payment for services. So if I were an air ambulance service such as yours, and I had a base rate, say it was $20,000 for your base rate and a mileage rate, and I went in network and had a contract with that payer, that would be one of 3 that could be used to establish the QPA for that payer to pay out to the providers. Now the problem is that in some areas there's a lot of air ambulance services, in other areas there aren't many, and so the concern was, will the insurances even have enough contracted in-network payers to actually have 3 to have that median rate with the QPA. So there was anxiety about this right out of the chute, not just in our industry, but in healthcare in general, because generally speaking, the concept was, well, if it's a hospital-based program, they're going to bundle it with other services, it's going to be a low dollar value, and everybody else who's not hospital affiliated is going to have a QPA, or a payment amount, that's going to be a lot lower than what they need to meet their costs. And that was kind of the working concept that a lot of folks in the industry had, right or wrong, right? They weren't looking at the data, they were just saying, hey, this is what's going on. So needless to say, there were several lawsuits that were filed, and these slides kind of go through some of the history, not all of the history. There is definitely a lot more litigation that's happened. I'm not an attorney, I'm not a lawyer by any stretch of the imagination, just try to follow this and keep on top of it for our partner programs. But in our industry, the Association of Air Ambulance, it's called the AMES, Association of Air Medical Services, they filed a lawsuit right out of the chute and said this isn't going to work, this is not going to benefit all of the players in the industry. They focused on this QPA being presumptively correct, like is the insurance, are they being totally transparent, is that the good number, and how it gets weighted. So they were very concerned about that. They wanted to include things like single case agreements, whereby a very common practice when you're not in network and you're transporting a patient that you may never transport for that insurance plan in the next few years, they'll sometimes do a single case agreement at a much higher percentage of your billed charges. So they wanted those included, but the law had clearly excluded those. And they wanted some other changes in there. So AMES was kind of first to the chute for air medical laws, while all these other kind of rules were being established. The Association for Critical Care Transport, which is a patient advocacy group in the air medical industry, didn't agree with AMES. So there's a big separation in industry in terms of, what is the right path to go, and programs were finding that they were having to pick side. Were you advocating for patients, or are you looking for the biggest dollar? So this has gone on. We've had a lot of activity here in the state of Texas. As you probably have heard, Texas Medical Association was the first to go to court on the hospital side of things. There were many other lawsuits involved, and the court in East Texas actually was the one that heard the first case, again, related to the presumptive QPA and whether that was the right number or whether or not it was interpreted from the law correctly. Part of what was going on in all of this with CMS is the language that is used to explain what is in the law into rule. And TMA filed suit against that presumptive QPA language, and they were successful. Then we had LifeNet of Texarkana, Texas, which is another private, a different model type, file a suit relative to the air ambulance and the QPA specifically. And in the scheme of things now, there have been 2 other lawsuits in East Texas. One will actually be heard tomorrow. Because the first and second lawsuits combined with the Texas Medical Association have been very successful. And as the rules have rolled out and the language has been ambiguous or has been different from the original law, the court in Texas has been very, very good about hearing the cases and kind of navigating that. So you're going to see a third case or hear about that in the news very soon because it's going to be heard tomorrow. But again, really trying to get at what is the correct payment methodology, how should the independent dispute resolution process, which is supposed to be hearing these cases, how are they to be following the steps correctly. That's kind of really the essence of it. There's a whole lot more deep in the weeds, but I want to keep it high level, kind of give the big picture, and then we'll kind of focus on Washington County. So in terms of the actual, I'm going to move through this. This is kind of what I said in long version in case you wanted more bullet points. And you have a time crunch, so we're going to keep on that. In terms of the actual law, in terms of what is in it when you break it down and look at the specifics for air ambulance, it's got good stuff in there. It really does. So as of January 1st, 2022, it was the end of all balance billing for any commercial insured patient. So it limited any out-of-pocket to just their copay and their deductible, which was huge. So if there was a program that had a $70,000 ambulance bill, the insurance paid $30,000 of it, that other $50,000 was straddled on the patient's back, and that's what we saw in the news, right? Mm-hmm. And so now that doesn't happen. It's not allowed as of January 1. The other thing it did is it enabled any cost-sharing payments that those patients had, if they were, because ambulances was out of network, the ambulance service is generally, in many places, out of network, it allowed that to count towards their out-of-pocket maximums, which it never did before. So very, very patient-friendly, very, very much part of what the spirit of the NSA was supposed to do.
If a person doesn't have insurance, though, when you say copay and deductible, if a person doesn't have insurance,
it's a whole different, that's
it
a whole
is a
different
whole
category.
different ballgame because they will have to pay it all.
Not necessarily. It's a whole different ballgame, but in many cases, yes, there are providers who will try to recoup the 100% from that patient, but there are other compassionate billing programs and things in place to help those in many areas. Not all, but in many areas of the country. Other good things this did for providers such as Washington County is it required the insurance payers to pay their premium, their payment for their services directly to the provider. Mm-hmm. In the past, prior to No Surprises Act, if the insurance did pay for an out-of-network service for an air ambulance transport, they paid that directly to the patient. So the patient got the $20 or $30 or whatever $1,000 check, and then it was up to the provider to get that money from the patient before they skipped town, paid off their boat,
well, that's
put their
bananas.
kid, yes.
Yeah,
So
that doesn't make
so it was a bit of a crazy thing, so that's been ended. So like I said, there were some good things that came out of this legislation. Pre-notification to patients in non-emergency care situations, so they know what it's gonna cost if they don't have insurance or if they have an insurance that doesn't cover in a non-emergency situation. And the other thing it did is it said patients were no longer allowed to be in the middle. So one of the tactics that used to happen prior to No Surprises Act in the air ambulance space is when that patient's insurance did pay for only part of the balance, the providers oftentimes got the patient in the middle and said, hey, look, I know you're on your deathbed. I know that you're in the ICU. I know you're sicker than sick and you got a lot on your mind. But if you don't help us get this paid with your insurance, then we're going to make you responsible for it. So there's a lot of harassment of patients to get them to get their insurances to pay. And it was very successful, I will say. A lot of insurances then said, okay, whoa, we don't want you harassing our member. Of course, we'll pay some more. We don't want them to be, in debt for the rest of their life. We don't want them to, mortgage their home or have a lien put on their home. So that was successful in some areas, but not always, right? That's why we still had those cases in the news. And then for the uninsured patients and the people that are true self-pay, there's a whole process for good faith estimates of what this will cost and sharing so that they have some transparency to what's going on. But the thing with air ambulance is it's an emergency service, so a lot of that can't be done in advance. Exactly. So there are some flaws with some of the thinking here, but again, overall, there were some good elements in the No Surprises Act for air ambulance billing. The controversial pieces I kind of highlighted in the structure of all of the litigation that's been happening and all the news that's happening is that if you are out of network and you receive that payment from your payer and you disagree with it, you think you should be paid more, you've historically been paid more, it costs more than what they're providing you, you get an ability to negotiate with that payer for 30 days. And if the payer pays you more, great. If they don't, the process is you now then go to arbitration. And it's baseball style, where the provider makes an offer and the payer makes an offer, and it goes to this independent dispute resolution entity, and they decide based on the information that they have and the two offers who wins. And so the fundamental structure of this was, okay, great, we know what the law says. The law says you can't include any information about your charges. You can't include any reference to what state Medicaid would have paid or what the Medicare rules would have paid. It's strictly about what you believe your program deserves for that service. And it gave even more structure for air ambulance. It said, we want you to argue based on your quality and your outcomes, your patient acuity and the service complexity for that particular transport, the quality, the training and experience of your medical personnel, the vehicle, the capability of that vehicle, the population density where you're picking up, as well as any efforts that you've made to go in network with those out-of-network commercial payers, right? So they gave us some really good structure to work with. The problem is when the rules were written by CMS and rolled out, they didn't focus on this, they focused on the QPA and how the QPA should be used, and that's where the big controversy has come in, and they added language that it should be presumptively correct, whatever that insurer said was their QPA amount, with no validation, with no real auditing, no real checking. So that's a lot of the stuff that's being challenged in terms of the IDR and the law. So for out-of-network payers, the law also had some specific requirements for them as well, that they are supposed to pay the claim in 30 days. So you send in your claim and your documentation. Payers are supposed to make their first payment in 30 days, and that the patient responsibility portion would be treated as if they were in network, as opposed to saying, well, you're out of network, you have a higher copay and deductible. They were to assume as if they were in network, which again is good for the patients. And then there's a 30-day period for open negotiation. And the spirit of the law and everything that I understand from the folks in DC that were working on this was that 30-day negotiation period was supposed to be a time where there was good back and forth between the payer and the provider, and that things would get resolved then and there, and you wouldn't have to deal with the IDR. And the rule said you had to exhaust that 30-day period before you could move forward with the IDR, and they created very strict timelines for that practice. Well, in actuality, what happened is payers didn't want to negotiate, they didn't care, they wanted to try their luck at the IDR because the rules had written in language that they were presumptively correct and things had to be materially different than what was originally billed. So it kind of, the rules led more favor to the insurance providers than it did to the actual air ambulance providers. So as we look at this, and you guys following me, I'm kind of keeping it high level, trying not to get bogged down in too many details. So, you know, how does that compare to pre-No Surprises Act? What is kind of the difference? Well, in the prior world, when you had a payment dispute, you had an appeal process. So if Washington County received a payment that was less than what they thought they deserved, they could appeal it, and they could work with it, you know, and there weren't really any bumpers on how long that took, or, you know, what process it could be, should be followed, and it was different for every payer type. You know, Blue Cross could have something different than Aetna, could have something different than Cigna, and it was up to, you know, you follow the rules for that payer. And sometimes those appeals could go on for months or years. And under the No Surprises Act, we now have a very structured process in place with very, very specific bumpers for when all the things should happen, but it's not happening any quicker, it's actually happening slower, because there's an overwhelming volume of what's going on in terms of disputes. So in reality, they thought things would move through the open negotiation and have a lot more success, but we didn't see that over the last year. What we saw is more claims go to IDR than what the government anticipated, relative not just to air ambulance, but in terms of all healthcare.
So wait a minute, can you explain something to me?
Absolutely.
So why is the IDR like the path of least resistance? In other words, why are these patients saying, okay, I don't want to negotiate with this person for 30? Is it because they feel like the negotiation would be just definitely get them to the IDR anyway, or and just slow the patient down, or?
So remember, the patient's taken out of the middle of this now.
No,
So
I mean
the provider. So what's happening is that initial payment, which used to be a decent, healthy amount, is now being paid at very low amounts. So that initial payment that providers are often receiving looks a lot like what Medicare would pay, even though we're not supposed to talk about Medicare. When you do the math, oftentimes it's exactly what it is. So providers are getting less money on their first check many times, and they're trying to negotiate, but the payers aren't willing to talk many times because things are in their favor in terms of
Gotcha.
how the rules are written,
Mhm.
which has
Okay.
forced
that
us
makes
to
way
the
more sense to me now. Okay, I wasn't following it first, so now I
Gotcha.
gotcha.
Yeah.
That makes way more sense. Okay.
So, and we only have 13 IDRs for all of healthcare. So 13 entities had been vetted by the government, by CMS, and set up to do IDRs for all of healthcare. So physician groups, inpatient, hospital, everything goes through these 13. So if you look on
So
this.
it basically
it's a
used to be a
bottleneck.
provider's game, and now it's a payer's game, because
Yes.
what the law did is it said, okay, this used to be a buyer's game or a provider's game. Now we're going to put it in the hand of the payer.
And that may
And-
not have been intentional
But that's what happened.
in the law, but that's the reality of what
Got
we're
it.
seeing play
How
out,
many
correct?
did they think would go through the IDR process?
So the tri-agencies, when they did their math and set up this whole process and they vetted the IDRs, they estimated there would be 17,333 claims go through IDR in the first year.
70,000.
We saw 17,000. We saw, according to a report by AHIP and Blue Cross Blue Shield, 275,200
Yeah.
disputes
I assumed with only
in the
13,
first
it creates a massive
9
bottleneck.
months
Yeah.
of the year, right? So
Oh, wow.
massive amounts of IDRs
Yeah.
for all of healthcare, and air ambulance is mixed in with everybody else. So
Yeah.
it's
All of it.
not just
Yeah.
us. The only
Wow.
group that's exempt from this, really, and again, we're talking about commercial payers, are ground transports. Ground transports were not packaged into the law in the same manner. Ground transports got a parking lot. We're going to set up an advisory committee, and we'll look at this later on. So we don't have any ground transports clogging this down. This is just the rest of healthcare. So then while you have these lawsuits happening and you have these rules changing, CMS has had to twice shut down the IDRs because they had to rewrite the rule based on the successful litigation that happened with Texas Medical Association and LifeNet here in East Texas. So they had to correct and redact the language that kind of modified the rule. So that's kind of where we are right now. As of last month, the IDR just got up and running again with new direction, new kind of updated and refreshing the rules, and things are finally starting to, in theory, move along.
The log jam is clearing.
But the log jam, well, it's slowly clearing because all these new things are still coming in,
Yeah, 'cause
right?
you still have to take the bottom log out. Yeah.
Exactly, exactly. And then what happens is once the IDR makes a ruling, then whoever loses, there's got to be some adjustment in terms of payment. So if the provider wins, they're due extra money from that payer, then they're still waiting to get that money in because now those payers are still holding on to that money. There's no real fork
There's no
in the
law.
law that basically says, hey, even though you're supposed to get paid within 60 days, there's no enforcement of it. There's no follow through. So what we're seeing is it's taking even longer once you win an IDR to get your money. So this is what's happening in the landscape now. If you look at Washington County, one helicopter, you've got a service area, your payer mix, what your commercial out-of-network is because you're a startup, that's part of what and you're dealing with, and you'll be able to hear what some of that financial impact is. Imagine now you're a bigger area ambulance program and you've got 10, 20, 30 helicopters, what the impact is if you're out-of-network, right? So there was a big rush to go in-network. A lot of programs tried really hard. Hey, we've got a package. This is who we are. This is what we do. We want to be in network. We don't want to deal with this.
Yeah.
But the payers really aren't compelled to negotiate right now because things are
You're
kind
right,
of in their
'cause
favor.
it's working in their favor,
Yeah.
absolutely.
Correct.
There's no incentive.
Correctly. Correctly.
So Doremus, this is a question for you. When you give us numbers, you're giving us those numbers as if you've lost the IDR.
No, sir. What we're giving you cost, cash per trip, knowing that some of that IDR payment process is still coming.
Right.
So, and she's got some of those numbers on a few
Yep.
slides here in a minute.
Okay.
She'll talk through on our billing side. But
Mhm.
right now, like our cash per trip is 7,000 or something. I don't have it in front of me. But the lowest payers don't have to go through this.
Mm-hmm.
Right? She said Medicare is not, that's for commercial payers.
Mhm.
So Medicare, we know what we're getting from them, and it's not a lot,
Mhm.
right? But we get that up front. So our cash per trip may look low right now, but the higher payers are bottlenecked into
Mhm.
this process.
Mhm.
So we're still expecting some of the highest payers to pay on this.
And you may not get,
100%.
let's just say the 100% is $20,000. You may not get that,
May
but
not.
you may get 15 or 10.
Right.
Yeah, but
But your
didn't
reports are reflecting what, excuse me?
Okay.
Your reports are reflecting what?
Our reports are reflecting actual dollars.
Actual, that's what I
Actual
want,
dollars
point I
we
wanted to
received.
make.
Yeah.
Right here.
Yep.
We have a spot there pointing to an arrow that says, this is the dollars we
Expected.
actually
Right.
think we're going to
We haven't
receive.
expected.
But this is what we've actually.
Yeah.
Right,
And didn't
okay.
you?
Yeah.
Just wanted the press to
Didn't
understand
you
that.
mention though that because the way our model is set, what our billing is below the industry standard, that they're kind of passing those through much more
I think we're in a
easily.
very favorable
Right.
Yes.
baseball arbitration position.
Yes.
Right.
Is what I would say to that,
Right.
right?
So,
Because
and that's
lower,
one of the
yeah.
things that's very important to mention is that there are different kinds of air ambulance services in the market, and I don't, that's not why I'm here to talk about that, but they are stratified by how much they charge.
Right.
And there are programs like Washington County Air One, the guys wearing the white hats who are doing the right thing, trying to provide a service, charge reasonable rates to get their costs covered and have enough of a margin to be able to continue on in perpetuity, right? They're not out
Right.
price gouging, they're not out, paying up high chains of leadership and ownership, right?
So I would say the difference is because we're a government entity, we're not trying to make money off
Yeah.
of our constituency.
Correct.
We're trying to
Correct.
just squeak by and
Correct.
provide a service, hopefully
We're trying to cover
budget
costs,
neutral.
not make a
Right,
profit.
not
which
make money.
which is exactly where you should be, and that
Right.
is the philosophy that my organization Metro Aviation takes with all of our customers, because that is doing the right thing for the patient at the right time always. I mean,
Right.
that's really what in our minds it should be about. But that's not what the rest of the industry does. And
Right.
here in Texas, when you look at your market and the fact that you're out of network, you're going to have claims that get caught up in the system because you have other model types in the market that are at a very different price point. And you then become one of the things that the payers are likely looking at when they're deciding, you know, how they're going to make their offers and what they're going to do. So we believe you are, yes, in a very favorable position. It's just the fact that you are out of network that you get caught up in this, where they're not actually paying you right out of the chute the way they normally would, because right now that's what they're doing for everybody. And so we end up having to go through this process. I should say, your EMS, I look at it as a team effort, but EMS, MC, and the billing team, you know, have to go through these hoops to deal with this. Now,
Well, and
But
I
ba-
think
yeah, go ahead.
I think the point to make here is this. The reason we went with Metro, and a lot of this was misunderstood, is that we align with your philosophy
Right.
of being patient-driven
Right.
with our medical side. We have, as long as I've been here, Director Doremus has told me, Commissioner, I'm not here to make money, I'm a patient-driven organization. When we went with our billing company is a patient-driven organization. Now we have, it's a three-legged stool, and we have all three of us on the same philosophy,
Yes.
that we're patient-driven, and we're not here to make a huge profit on people at their worst time of need. So I think that is very important to point out at this point in this stage in the game of your presentation.
absolutely.
And that relationship is those relationships is what's made this and is going to make this successful.
Absolutely, 100%.
I was gonna ask, you know, because obviously, you know, or I should say Director Doremus has had a good, you know, tap on what our payer mix is. So, I mean, overall, based on, you know, the coverage, because I know my understanding was we also have a significant number of folks within the county that have, they have dual providers, correct? Isn't that correct?
Sure, yes.
Yeah. And
You're talking
so.
about insurance providers?
Yes,
I'm sorry.
and so with that being said, I would imagine that, but then again, I don't know. But I would imagine with that beneficial payer mix, which is why all these private entities were wanting to come here,
Yes.
because they had dollar signs in their
Correct.
eyes, you
Correct.
know, which is why Director Doremus did a good job of keeping the hounds back, you know. But I would imagine that our percentage of out of network is gonna be much lower. Would you say that compared to perhaps other, you know, districts or?
I'm gonna let Kim address that she's got some slides about that.
Oh, okay.
Yeah,
Okay.
so if you don't mind holding that thought, she's got a slide on
Okay.
that.
I got one question about the
Yes, sir.
IDR process. Once it, so-called win, if we're talking about arbitration, and say there is that $20,000 left over, and you said you might not get it all, is there an average, I mean, how do they determine about that, what you get over that cost?
So that's really what comes out of the IDR's determination. So you get to say, this is what we believe we need in terms of a full payment for this transport. The payer is saying, this is what we believe it's valued at. And then you argue based on what the history of that particular transport was, you know, what the patient acuity was, all of those factors that are allowed in the language of the law. When you win, if the insurance had originally made you a $5,000 payment and your $20,000 offer wins, then the insurer pays you that additional $15,000 and they reimburse you the fees that you had to pay to go to the IDR. If you were to lose, say you offered 20 and the insurance offered 18, and the IDR says, well, no, you're only gonna get 18, then you would get that additional, you had 5, you get the additional $13,000, but then you end up having to pay for the insurance provider's IDR fees, is kind of how it
I think maybe one
works.
of the questions, I don't want to ask for him, but is there an average that you're seeing across the IDRs in general that they're receiving at the endpoint?
So it's generally from our program base, and I can only speak to the partner programs with whom I work with Metro Aviation, it's averaging out between 80 and 85% of your bill charge rate. And that's
Okay.
gonna vary based on where your rates are and, you know, who the insurance, that's
Wow.
about the average.
And so
of
is
what I
that, is
see.
that where you're basing your projected numbers
Yes,
on it?
Yeah, that's
Yeah,
where
if we
we,
get that, we're gonna be pretty solid.
And that goes to the point of you having a lower number from the get-go,
Yes,
that
sir.
it's easier to get that.
Yep.
Yes.
because that's what you had figured into the pro forma prior to us making this decision, correct?
Yep.
Yeah.
Exactly.
Any other questions on the processes? And I think I'll hand it off to Kim and let her kind of talk some more specifics about
Mhm.
Washington County, because
That's why the decision
her
was
company
easy.
does that and I don't.
was.
Although we work partners.
It was a no-brainer.
So.
Yeah, so
I don't-
if you've ever seen Moneyball, there's always someone that goes and arbitrates. They're fighting that fight for us.
She's-
on the
Right,
daily.
comparing to everybody.
Yeah, my name is Kim Stanley. I didn't do a proper introduction earlier. I have been with the company for 20 years, so we're a billing company located in North Carolina. We've got a lot of Texas clients, actually. Washington County was one of our first. And so Holly helps us from the perspective of understanding IDR, and she's actually created a document along with Kevin and Amy that puts together all of the things about the program. And so with that IDR, we submit this document to them that talks about all those 6 items that she talked about earlier. So the quality of the program, the vehicle, the cost of actually providing the services. I wanted to share just some information just so we can see, and I think this speaks to your question earlier on what is that payer mix.
Right.
And so I really just did the high-level categories of Medicare, Medicaid, insurance, and patient. Keep in mind, this is just your air ambulance billing demographic. And so you can see where we really fluctuate a little bit between Medicare and
Yeah.
insurance, and it just depends on, and because that number of trips each time is about 25 to 30 each month, 1 or 2 trips can make those percentages higher or lower.
So the purple line is our uninsured.
Yes,
correct?
that's correct.
Yeah.
The purple line is the uninsured, the green line is the insurance. So that's the commercial insurance, taking out Medicare's, Medicare Advantage, Medicaid programs, just those that fall under that IDR.
Mhm.
And there's actually a smaller segment of that as well. So of the insurance plans, if they are a self-funded plan, or an ERISA plan, federally legislated, they do not fall under this, no surprise. So even of the commercial bucket, it does not mean that everything falls under the NSA, just as an idea. And I'll have an example of that in just a minute here. So this is just to give you an idea of where we are in terms of charges. So that blue line is what we're billing out. The green line are the payments being received. And so as
Those are combined billing, it's not just one.
as Chief Dramus was talking about, you know, we're still expecting quite a bit to come back in from the IDRs. Air ambulance, it's interesting because a ground ambulance claim I can submit to Medicare and Medicaid, and I'll get payment within 14 to 15 days, really. Air ambulance, they usually want to see a piece of the documentation. They want to see the call report. They want to review really what happened with the patient, and they need that on paper. So most of the time, air ambulance do have a little bit longer of a lag time, even with some of the more common payers like Medicare and Medicaid. Obviously, with commercial insurance, it's much longer process for
I
us
think
to
that's
get
a really
paid.
good point because, throughout this program, there were some false rumors out there that, some of these flights weren't necessary. And I think that this establishes the fact that there's no way that
That could happen.
that's going to happen because we would be completely upside down if we
You're
were
not
just
gonna make
arbitrarily
it work,
Yeah, because you can't make a case.
Correct.
Yeah, exactly.
Yeah, so with-
They're, the providers, or even through the IDR process, they're gonna go through and they're gonna validate that air transfer was necessary. So I just wanna make sure, media, y'all have that, because that was a big rumor that I had to spend a lot of time having conversations with people, that is not what's happening.
And the biggest part of that is it was an insult to your organization.
It was.
Because
It was.
at the end of the day, you guys are patient-driven, and
Yes.
that flies in the face of that.
Mhm.
And so I just want you to know that while those rumors were there were members of this court that were saying you're false.
Right.
And we're-
Members of
because
this court, and
that-
then also, never mind.
That, but I'm just saying that is what
Yeah.
you need to understand. We believed in you guys because we understood the relationship.
Sure.
Not everybody in our community understands the relationships that have been forged over the process of getting all this together.
Right. And keep in mind too, Washington County has the compassionate billing program for the county residents as well. So, and that lends itself to some of these numbers that we'll talk about, and you know, we're not, she told some horror stories of things that are going on in the industry. That is not happening here in Washington County. We can promise.
Did y'all hear that?
Another good
Did y'all
point of
hear
reference.
that?
That's right. So I wanted to give you some idea of the independent dispute resolution process. So we have 22 commercial trips pending. If they do not meet the 85% of gross charges is when we will appeal back to the commercial insurance for additional payment. And so we have actually 10 in open negotiation. And so as Holly said, they keep us to a very strict timeline within 30 business days, and you have to count the 30 business days. I personally, when this became a law, I was personally creating and submitting IDRs because I wanted to see for myself how the process was going to work, how do we develop a process around it. It was new to everyone. And so I remember one day I did all the work and I submitted this nice IDR proposal, and I got it all rejected because I was on the 29th business day. And so just from that purpose, I wanted to illustrate it. It's a very, very strict timeline. So we have to give the insurance company 30 business days for open negotiation. As Holly said, we know that we're not going to hear from them in that 30 days, most likely. And then we're going to go and move toward that IDR submission.
So you have to wait that 30 days.
We-
They will not let you even
Absolutely.
submit it
And
early.
we only have 3 business days after the 30th business day.
Oh, wow.
So you
So
have
it's
to
just a
make
3-day
sure that,
window, don't
yeah.
So it's 30,
It
because
is-
on one
it
of the
is
other slides,
totally
I noticed
payer-
where it said 30 calendar days and then 30 business days.
Two different parts of the process, so in terms of getting your claim in and submitted.
That's
they
the
have-
calendar days,
They have
right?
30 days to make their payment.
And that's business days, correct?
And then you have the 30 business days for that piece of it.
For
Yes.
the open negotiation,
Yeah, so
yes.
it's- You
Yeah,
gotta pay attention to the calendar versus the business days.
Let's put some
Exactly.
Calendar alerts on there.
Yes,
Yeah.
that's right. And that's honestly what I was doing, is putting calendar alerts. I will tell you from our process, we have a dedicated person that just handles these for Washington County. So the amount of work that goes into processing 22 claims, it's a dedicated resource that she's following up on these on a regular basis. So we've actually submitted 12 IDRs so far, and most of them are actually in that process that Holly talked about. So they're somewhere within that 275,000 waiting to be heard. We've had 2 resolved. So one we won. So the very first one, the other insurance company did not submit a proposal. So we automatically by default won that IDR. The second one it was a self-funded plan, and it was reversed back because it did not fit under the NSA. So I brought that up to say that that's a little bit, that's another part of that puzzle. And then I was going to show just our average gross charge for these commercial claims is about $34,000, and that's including your base rate and your mileage, which again is very low compared to the industry. And then our average payment amount that we've received so far is about $16,000. So all of those are in the process, whether they're under open negotiations or the IDR has been submitted. And I'll say Blue Cross Blue Shield of Texas is 73%. And that's not calling out a particular insurance company. I just wanted to say that that's the payer mix of that commercial insurance number that you saw. The majority of that's Blue Cross Blue Shield. We have a couple Cignas, Aetnas.
Of
They're-
those trips pending, or would be 73% also?
Of the 22% of the 22 trips that are pending, either open negotiation or IDR, it's Blue Cross. It's heavily weighted toward Blue Cross Blue Shield of Texas. That's
Yeah,
correct.
sure. For this area, I can believe that.
Yes. So I wanted to switch gears just a little bit because Chief Doritas had asked me to also talk about where does ground ambulance fit into this? How are we moving in that way? And honestly, we are. I mean, there's going to be some type of ground ambulance, no surprise billing legislation. As Holly said, it was parked for a little bit, and they're going to create this ground ambulance and patient advisory committee. We have a legislative liaison that's worked with me for many years. She's become an employee over the last 7 years. She's actually going to have a seat at the table on this committee.
Wow.
So there's 12 individuals that were, it was congressional appointed committee through the Biden-Harris administration, and she'll have a seat on that table. I've been asked to present to that committee as well, and I'll share just a few of those highlights of what I'm going to. They did delay, so they were supposed to meet in January. They are now going to meet the first week in May. And so all those presentations, all of those are public. So they'll actually have a public Zoom link, and anyone of the public can actually attend those meetings. Now, if we do not get there on the federal level, I believe that we'll get there on the state level. We already have 33 states that have implemented some type of balanced billing provision, and actually got word just this week that Texas actually has, through the Texas EMS Alliance, they have proposed legislation, and I think it's Senate Bill 2574, where they were asking the insurance company pay us 325% of Medicare allowed amount, and therefore if we are able to successfully legislate that payment amount from the commercial insurances, then we choose not to balance bill the residents. It's a huge benefit for Washington County because you're not billing the residents anyway. Now, we will probably not end up there. We will probably negotiate down from that number. But that's at least a starting point where there might be a state-specific law that goes into effect rather than the federal law that might be coming.
And the reason that's beneficial to us is because currently we don't bill for that money. That's money we're leaving out on the table, and we would end up getting a portion of that wherever they land with that 300%.
Sure, that's
That's
correct.
phenomenal.
Yes.
Yeah.
So your Senator Hochhorst and your state rep would be good to get a hold of that bill.
You ain't lying. What was the number?
It's Senate Bill 2574, yes.
I'll send you a link to it.
Yeah,
Please
will you
do.
send all of us a link,
Send us all a
please?
link for that.
Yeah, that would be great for us. So as I said, now,
need to call.
because they've created this GAPB committee, as I said, our employee Regina is going to be involved in that. They're going to meet in May of 2023. However, the proposed federal budget came out just a few weeks ago, and it already extends No Surprises Act to ground ambulance. So there's a lot of discussion. Of course, it's the proposed federal budget, so it still needs to be passed by Congress, and Congress is the one that actually created the committee to discuss it. So it's kind of the cart before the horse a little bit, but it certainly tells us which way the administration is moving in terms of creating a ground ambulance program that's under the No Surprises Act. So we did some data, and this is part of what I'm going to present to that committee. So, from our business perspective, we wanted to see, okay, let's say we can no longer balance bill patients for ground ambulance services. What does that mean to us, kind of if that were implemented tomorrow? And so we did a lot of research, and for a commercial claim, and when I say commercial, Blue Cross Blue Shield, Cigna, Aetna's, healthcare claims, our average billed invoice on a ground ambulance is about $222. That's actually billed to the patient after the insurance company has paid. And of that, we're collecting about $108 of that. So almost 50% collection percentage on those copays and deductibles and balance bills, essentially. Now, again, Washington County is a little bit different because we don't balance
We
bill the
don't balance
residents.
bill.
That's
Yeah.
correct. So this is just our data, and we'll process about 3 million ambulance claims. So
Meaning the impact, I see you looking around, wouldn't affect us as much as it would others.
Yes.
We're already not balanced billing.
Correct.
Right.
We're not going to be fighting that because we have no fight in that.
right.
Yeah.
Because we don't do it now.
balance bill. That's right. But if I said all balance billing goes away, the average revenue from a individual service would be about 5% of the revenue. So it's not, commercial insurance really represents about 13% of our overall business. And of that 13%, just giving you these statistical data, It's about 5% of our overall revenue that is collected from the patient after balance billing. So my illustration of this is it's not the end of the world. And especially if we were to get a Texas legislation such as the Senate bill that I was referring to, it would mandate that payment made directly to the service rather than to the patient. We're going to get 325% of Medicare, and we don't have to go to the patient. We're causing those insurance companies to pay more and taking that responsibility even more so away from the patient. And frankly, I'd sign up for that all day long. So I think it is really advantageous to the system. And so those are the statistics that I wanted to share. Any questions for Holly or myself?
No, I think we asked them as we went.
Okay.
Yeah.
At least I did. I can't speak
Yeah.
for everybody else, but.
Quick
No, I
question on the
didn't hear.
Medicare and Medicaid, I know we talked a little bit about it before, about like the other insurance, like for fire or whatever, and we discussed about what does Medicare and Medicaid pay on the as far as their flight costs? There's a set rate, correct, no matter what?
It is. I don't
mean,
have that memorized.
Yeah, not necessarily the number, but
Yeah.
no matter what, they're on,
No.
there's a difference between Medicare and Medicaid,
That's
correct?
correct.
So if they're on Medicare, they can still be charged
They can be charged their 20% copay.
20%?
Yes,
Okay.
so Medicare will make and let me preface that to say if it's traditional Medicare pays 80%, patient is typically responsible for 20.
Yes.
If they're an area resident, meaning a Washington County resident, that's automatically written off.
Good.
If they have a secondary insurance, they might pick up that 20%. If they're Medicare Advantage, like, some of the commercial companies, you can sign up for Medicare Blue or Medicare Gold, or those are actually processed through commercial industry, but receiving Medicare funds, they might have a standard copay instead of, if you go to the doctor, you might have a $20 copay no matter what, or you might have a 20% copay depending on the service. So that's a little bit of the difference between the two. But yes, the Medicare is a set amount. That's based on a fee schedule amount that's created, and then it is increased each year based on an ambulance inflation factor. We just got one of the largest, I've been doing this 20 years, and we got the largest inflation factor, 6.2% this past year.
So
across the board.
did Core Health.
Yes.
Yeah, so the other side of this
We heard this
is,
on
and it's
the-
good that you asked about Medicare. What this law also does, it sets up a lot of reporting. So for air ambulance, there is a requirement in the statute for cost and data reporting of all your revenue, your expense, your operational model type, and all of that, which has never really been asked in that format. It is very, very complete.
Scaring a lot of people.
It's scaring a lot of, yeah.
Trying to gather that
Yes.
But for programs like you, I mean, you do that publicly all the time. It's not a big
all the
deal.
time.
Yeah.
TASK is a great example.
Yes.
Of everything that we report for TASK, the cost, how much the auditor's time, the treasurer's time, the cost of doing business. Really
Yeah,
all of it.
ours is out in the open.
Yep.
Yes.
But most in the industry, air ambulance industry, it is not.
Right.
Well, and there's a
The
reason. for it.
majority is private,
Exactly right.
correct?
Correct.
They
There's
don't
a
want
lot
you
of-
in
yes,
them.
Yeah.
there's a lot of
So they're
private-
in it to make money, not necessarily for patient care.
So that has come out in proposed rule, was supposed to be happening this year, but it got delayed because of all this other activity with the lawsuits, but it is still coming. CMS is gearing up for it, they've got their website for it. Round is already in that process where they're doing a 4-year CMS cost reporting cycle. It's actually down to a condensed version of that because of the pandemic. And payers, through this whole process, all of the payer data has to be reported as well, including the open
That's awesome.
negotiation and the IDR. So folks in Congress, we're looking at this as not just this is going to deal with balance billing now, but it's going to set us up for information as we address the Medicare deficit, budget and what's gonna happen
Well,
for Medicare.
And they need to do that because look, the federal government has got a lot invested in medical. I mean, let's be honest, Medicare and Medicaid are draining their budgets.
So a lot of folks anticipate transport reimbursement for Medicare moving much like healthcare, which is quality-based payment models. It's a whole different ballgame. And they don't have the data now to do it, but out of this act, they are going to accumulate most of that data that's needed.
Well,
so.
well, thank God. I don't know how many years ago it was that I met you, but when we
Probably
when we,
2011 or 2012. yeah.
okay, so when we started having those conversations about and Director Doremus said, look, we're going to change the way we do this. We don't want to do this the way the industry standard has laid out. Thank God the Commissioners Court gave him the opportunity to be innovative like that, because guess what? None of this is going to affect us in the way in which it's going to affect all these other folks, because we're already doing it.
Yeah.
That is so important for all of us to know,
Right.
not only us here at doing the, but our community to know that we were so far ahead of the curve. We are 11, 12 years ahead of the curve.
Well, if only the federal government can encourage others to follow this.
They are with this act.
This
That's
same
what they're
model.
doing.
That's
Yeah.
exactly
Yeah.
what they're doing.
That's what they're
Yeah.
doing. They're
I think
forcing
with
them
ground
to do it.
ambulance, we are actually anticipating the cost for ground ambulance to be higher than what we're actually getting paid by Medicare.
Right.
Because there are groups like Washington County that help to subsidize programs, and that's across the country. And so EMS has never really been paid the way that they should.
Right. So currently, right now, with all of this, supporting 80% of the total EMS budget, wink, wink, media again, it could be that at some point, this is, could be fully supporting.
Yes,
Be cool.
and we hope that that's.
Well,
emergency
basically, the
medical
bottom line
services
is-
in the county. Yeah.
Basically, the bottom line is, through this presentation, good news.
Yeah,
Yeah.
Good
And
news.
I do want to mention one thing, because there's a third leg to that stool,
yeah,
Amy.
Yeah.
Fourth leg.
She's
She's the
sitting
fourth
here real
leg.
quiet.
yeah. It's a four-legged stool.
Yeah, so she does all the hard work in our office for getting them all the information to take to the IDR, to make sure the guys are doing the charts, and weekly calls. They're on a call every Wednesday, I think, is what they're doing, to talk through every one of these charts that are going through the IDR process, or that might go through the process, or has come out of the process. So it has added extra work. The good news is, it's teaching us how to do it for the ground, because I think we're headed there.
Yeah.
So we'll be way ahead of that, because we went through it on the air, so.
Another important point.
What we're doing.
And we have done quite a bit of education going back to the ground on a lot of these changes, and
So you're starting to implement the reporting already, so that you don't have to do that, make that pivot
Later.
when the time comes.
Yeah, you'll just be able to,
Keep
Perfect.
in mind, our air guys are also working on the ground.
Yeah, so they know.
yeah.
And
Yeah,
I would
it's
say
better.
probably the only true pain point is it's taking you longer to get your money.
Yes.
Because of all of this, it's just taking you longer. But I believe you're getting it, you're gonna get it.
And
It's
we're
just-
fighting for it.
And
Yeah.
you've got a great advocacy team fighting for it.
Mhm.
It's just taking longer because there's so much bogging down the
And
system.
that sentence is really what I wanted you guys to hear.
Well, the other thing is this, is let's just hope and pray that that starts to create a problem for the federal government, and the federal government says, hey, we're gonna move this ball down the field.
I suspect after the ruling happens in East Texas on these two combined cases, TMA and, I think they're calling it TMA 3 and LifeNet 3, you will see a lot more activity in terms of advocacy groups trying to get more rules kind of cleaned up. Less tolerance for changing the law, but a lot more, let's just clean up the rules, let's just make them functional.
Yeah,
Mm-hmm.
and put some teeth into some of the
Yes.
stuff that's needed.
Yes.
Like once it goes through arbitration, pay us.
Yes.
Mm-hmm.
And that's some of what is gonna be heard
Hey,
tomorrow.
Need to put a timeline in on payments just as well as.
3 days.
everything
It's
else.
actually there.
Let's just keep it the same.
It's not being enforced.
Yeah, right.
3 days.
I'd go for
I'd
30.
go for 3 days.
Yeah.
While we're doing kudos, I have to say some great things about Kevin, because I said this to him earlier today. I'm around the country seeing very large EMS systems, and I can tell you that this guy's a real jewel in terms of innovative, developing new programs. I mean, the ACP program, one of the first people out of the gate with that program, and so he does a great job for Washington County, and I want you all to know that. So.
I didn't-
Well, now he's not gonna be able to get out of the room.
No.
And
We're
Lord,
Way to
very
go.
lucky.
yeah, but,
Amy, you
That's an
included
inflated
the-
head.
The whole team,
Wonderful,
we're very,
yes.
very lucky to have
Very
the
good.
leadership team.
I'll tell
that
y'all,
we
thank
have.
y'all for coming, taking time to do this today. It was very informative, very well
Yes.
put together, and
Thank y'all
well
very
presented.
much.
We love
Even I could
Texas.
understand it. So it was good.
Can we get a copy of that?
Yep.
Yeah,
TJ's
we-
got it, I'll get it to send it to y'all.
Yeah, we need to have that.
Thank you.
All right. Well, thank y'all so much.
And thank you again for
Oh,
the
you're welcome.
throat lozenges, and it helped a lot.
We've enjoyed the partnership and we
I
look
thought we were
forward
calling
to.
ambulance for you for a while.
Man, this has been going on.
You've had
Since-
this,
With
yeah.
you all.
Yeah, well, thank
Today,
you so much.
like
This
last
meeting-
night
too.
at like
we need to
9
make- do we
o'clock,
need to
I was
adjourn
like,
then?